So my job is to sort of compare and contrast to an extent Australia and the UK. I don't think there's that much difference between us. We still have the same head of state, Her Majesty the Queen, although there have been various attempts in Australia over the past few years to change that. I think we've got the same challenges in healthcare, and I'd just like to give you a bit of an overview of what's going on in healthcare in Australia at the moment. We're pretty similar to the UK in terms of our GDP spend per capita on healthcare, about 9%. And we've got the same sort of problems with increasing emergency presentations, 5% per year, increasing admissions of frail elderly patients, about 10% per year, and all the pressures that that brings on the hospital system in particular. Health in Australia is a servant of two masters. On the one hand, we've got the Commonwealth Government, which through various funding mechanisms takes care of, that is, funds, primary care and a limited amount of private secondary care. And you can see there that we do have a public-private divide there too. But hospital care is funded by the states. And so this is an absolutely ideal situation for politicians, because one group can always blame the other. And if you have, for instance, as we do, problems with emergency access, then it's very easy for the Commonwealth Government to blame the state government because, of course, hospitals are a state problem. But the state, on the other hand, is tired because half the beds are occupied by elderly, frail people who are waiting for residential care, which is a Commonwealth problem. So various attempts at reform have been made over the years to try and address these things. But I don't think we have the proliferation of reforms and different agencies that you have over here, but it's been pretty tough. Every time I come here, I have to have a bit of an update on the latest acronyms, and it's been extremely difficult to keep up. So I do congratulate you with the stamina that you seem to maintain. So the recent changes that we had in health reform were the introduction of what was called activity-based funding. And that is a way of devolving responsibility for the provision of services down to local health boards or networks. And it's been troublesome. It was the initiative of the previous government, so needless to say, the current government has decided to terminate it. And so next year, when that plan comes to an end, we can look forward to yet another round of reform and changes. So what set the agenda? I'd like to think it was a planned agenda in safety and quality in Australia, and it began that way, but like here, it's been dominated by a series of inquiries and disasters, and to an extent, the sort of incorporation of safety and quality into business as usual and hospital accreditation. So I'll just take you through a few of those things, which you might recognize. So this is a landmark study in Australia. It's the first quality in Australian healthcare study, about 1995. It's still, to this day, the most highly cited paper in the Medical Journal of Australia. And it followed on from similar larger studies from Harvard and Utah. But this identified that about 16% of hospital admissions were associated with significant adverse events, and really showed that Australia had exactly the same problems that were being identified throughout the rest of the world. And what was also important about this was it established safety and quality as being a legitimate field of academic inquiry. And so we saw early on quite a lot of physicians particularly, but clinicians in general, getting involved in safety and quality and being reintroduced, if you like, to research and quality improvement, and without perhaps necessarily having a lot of research background up to that time. So it was an excellent start. But that's good. At the end of the day, and I just come from a conference in Brisbane where Peter Pronovost from Johns Hopkins presented, we're still very unclear about what the major factors are that are required in order to improve quality. Pretty well all of these are involved, but the extent to which they're involved is still uncertain. Now, as I say, we can more or less match each of the inquiries that you guys have had over here. We had our own ones in Perth, Western Australia, where I'm from. inter-hospital rivalries often stimulate this sort of thing, and a few significant people were lost to the system as a result of this, which actually found that there was no case to answer. But more commonly, there is a case to answer. And we've had significant failures of clinical governance, particularly credentialing, where doctors have been admitted into the system and have perpetrated terrible acts on patients, which were only found out after the fact. We've had a series of failings in the provision of clinical care, often because of systemic underfunding, but which have resulted in tremendous stress for not just the patients and carers involved, but also the staff. So these are the things that really drive, or have driven, I should say, the development of the quality and safety agenda in Australia, as they have here. I'm just waiting for my own hospital to appear as the question mark on one of these occasions. Now, about 1990, we began to develop a series of clinical indicators. So we've now got almost 30 years of data on the use of clinical indicators routinely within healthcare. And these are national clinical indicators which have been incorporated into a process of hospital accreditation. And these have been supervised by the ACHS and have resulted, these are the sort of fields over which they are set, and they have actually driven a lot of change. There are problems with clinical indicators. Danny referred to these earlier on. I'm sure you've all got have identified faults with them and the problems. But nevertheless, they have driven change, and they have resulted in hospitals having to develop their own capacity to monitor these clinical indicators, and particularly to improve the performance of the hospitals. Through the work that they've been doing in the ACHS and this data that's been gathered over more than 20 years, they've begun to identify the characteristics of highly performing organizations that are doing well. And I don't think there's any surprises on this slide. They're the sort of characteristics that have been identified in other studies internationally. But I think one of the key things is the use of data, which, as you'll realize from my master slide, is one of the themes I'd like to finish with today, but also the particular engagement of consumers was a very important factor, and that's one that we've taken very seriously. And I know, for instance, that the Clerk has got that as a very high priority indeed. So we have been involved with patient groups now for a number of years. I think one of the leaders in Australia was the Telethon Child Health Institute just down the road, who not only have involved carers and parents of their children, but have had a particular focus on disadvantaged groups, in particular the Aboriginal community. So we have got a big problem with Aboriginal health in Australia and equitable provision of health services, which I won't dwell on at the moment, but would be happy to address later on. The other area that we've developed capacity along a number of different lines. So we've talked earlier on about having a common language and having an educated workforce in the area and concepts of quality improvement. And we've invested quite heavily in junior staff. We've had a number of fellowships, we've had a lot of training programs. We've worked closely with the Institute for Healthcare Leadership here in London, and we've had a joint appointment of John Clark across the two agencies, and he spent a fair bit of time in Western Australia. And I don't think Western Australia is unique in this regard. I think most health boards have identified the need to develop capacity with their organisations and to free up time for people to attend events such as this and training programs. But one of the consequences is sort of death by dashboard. So as we've incorporated a lot of these metrics into our normal working day, this is the sort of data that we're presented with. And this is not unusual. We're presented with dozens of these, and I'm sure that those of you who are in management, even middle management positions within your hospital would recognize this sort of thing. And this is a terrible abuse of data, and one that really has to be addressed. And it's nice to see such an emphasis on data here at the meeting today. It's also nice to see that when you go into the Clerk, the very first office you come to is the one that's got the mathematicians in it. And in particular, they've got a window, you know. I think that gives an idea as to how seriously they're regarded. So do make use of them. Okay, so my father was an accountant, so growing up I was quite used to the term audit. I'd never heard it in a clinical context until my final year of medical school, when I was posted to this remote hospital, middle of Scotland, up in a moor, Nissen huts. And as soon as I arrived, the house officer disappeared on holiday, and so I was it. And I spent a good bit of that time traipsing around, measuring wound infections and measuring drainage. Because the surgeon who was out there, a chap called Tony Gunn, who I think is really one of the unsung heroes of quality improvement, had identified the need for clinical audit. And together with Rosamund Brewer, one of the public health physicians, was an absolute pioneer. Remember, this is back in the sort of 80s or late 70s. And that was my first introduction to clinical audit, which has become, you know, obviously much more important now, much more embedded, I should say. He also was one of the first people to use a prediction model. So he used prediction models to look at abdominal pain. It wasn't particularly good in these days. And since that time, the number of prediction rules that are produced has grown exponentially. And this is another problem that we're going to have to face as we move more into the electronic age. Now, we've had a series of collaboratives over the years, and this was, I suppose, catalyzed by the Modernisation Agency's involvement over here in the UK in the early days. So we've had those involved with medication safety. We've had them involved with VTE prevention. We've currently got one on blood product management. And we've got the Choosing Wisely campaign, which I think you've had here, or you have got here under different names, perhaps. But nevertheless, the idea that we're over-testing people, over-diagnosing people, and over-treating people. So this is an attempt to try and disinvest in some of those unproductive activities. So these have been quite successful at a national level and have resulted in teams like this being built and people working closely together. We've also had a series of registries. I'm not going to go through them all, but our kidney and our ICU registries are highly productive and regularly get New England Journal papers out. We've also got the Australian Orthopaedic Association registry, which was one of the first to identify problems with metal-on-metal implants and cobalt toxicity. So these have also had an important role, and most importantly, they're driven by the doctors themselves, they're driven by the profession. Sure, there are variations in care, but we saw earlier on from Tom's demonstration that variations are natural, and you would expect that. The question is, when does variation in care become a serious indicator that there's something wrong with your system? So we're a bit behind here, but it's only earlier this year that we produced our first atlas of variation in healthcare in Australia, showing where we might target our interventions in the future. But again, this sort of data follows on from a lot of the initiatives we've developed here in the UK. And finally, I'd like to just mention the whole problem about data. Currently, the world produces an exabyte, or actually it's a couple of exabytes of data a day. And that's a lot of data. You go past terabytes, petabytes, and then you're onto exabytes. And the management of this data is something that's going to be an increasing problem. There are about 43,000 health apps. A lot of wearable technologies are now beginning to collect health data. We're using technologies to monitor movement in elderly patients. We're using monitors to test the effectiveness of treatment in Parkinson's disease. So all of this data has to be managed, and it's going to be a very difficult task, and there's going to be a worldwide shortage of data scientists who are able to handle it. In Perth, we were one of the first to develop data linkage until privacy laws really disrupted that. But we had 30 databases connected and were able to do some incredibly innovative stuff. But of course, that generates huge amounts of data. And we have to now develop ways in which we can bring the sort of data that you generate, which is relatively small scale, but which I should say is very rich in its information content, and which, if combined with some of the larger databases, might be even more powerful. But we have to develop mechanisms by which we can bring in our daily information from the health records to some of the other sources of information that we're going to have in the future. MRI and other imaging modalities are commonly used and generate huge amounts of data. This is functional magnetic resonance imaging, and you might recognize that it's not actually a human subject. This shows the activity in the brain of a salmon. And the only problem about this is that it was actually a dead salmon. And the chap had just picked it up to calibrate his machine on the way into work. And unfortunately, what it identified was that there are major problems with the underlying statistics that governs the analysis of these data that was embedded in the hardware of the machine. And this, and a study earlier this year published in PNAS, indicates that perhaps 40,000 fMRI studies using this same software are potentially fallacious. Huge impact. You might recognize this as a heat map. There was one shown earlier on. And you don't have to know anything about heat maps. This one happens to be a genetic heat map looking at gene expression in tumors and what have you. You don't have to know anything about them to identify something about these. Sorry? They're the same. Thank you very much indeed. They're identical. But the only problem about that was that they're from two separate papers, reportedly showing two different responses to chemotherapeutic drugs. And this was the first indication, or one of the early indications, that the particular group that published this had a problem. It turned out to be one of the biggest scandals in modern medical history. A whole clinical trial had to be abandoned halfway through, and Duke University was seriously compromised by this. But this was a problem about data management. And now there's an increasing emphasis on data custodianship and curation during the whole process of doing studies. And it's now not enough just to generate your article, but now you're expected to have your analytic code included as a supplement at the very least. And in many cases, you have to put your data into a repository. And I think this is an area that we'll see in the future. And I think you guys could actually lead in many respects. Data presentation, data visualization is very important, and this is probably the only proper use of a pie chart, if I might just say that. These days, we've got many more sophisticated tools, and that's why you've got this group in the corner here. But the trouble is that these tools have to be wielded with a degree of expertise. And I found, reviewing various projects, etc., that they're being wielded by people who don't have the expertise. And you have to work very closely with your data scientists and mathematicians in the future.